can find this difference between a cirrhosis and the normal liver. Yes, you can find the macronodular structure of the pathological cirrhosis and presence of ascites and the differential diagnosis between the normal liver and the cirrhosis. And you, as a family physician, can put the diagnosis very easy. And also, if you have some causes of pain in the right hypochondrium and epigastrium, you must make this POCUS, and you can find, if you have the right hypochondrium and epigastrium, you can have some common bile ducts pathology like biliary litasis, the cholecystitis, the obstructive jaundice, and the colon. You can have the colitis, the diverticulitis, the tumor, the ischemia, and to the hepatic you can have some diffuse lesions and also some focal lesion, and the pulmonary. Don't forget the pulmonary in these times, the pleurisy, the pneumonia, and the embolism, the pneumothorax. And also you can have the problem, the pathology of the kidney, like stone kidney, and like a pyelonephritis, like a tumors. And if you have the pain in epigastrium, don't forget to look to the pancreas, to think about the cardiac causes, to the stomach causes, to the vascular causes, and so on. And we tried in next minutes to find some section, some standard section, like a longitudinal section. And you can find this paramedian longitudinal section with the presence of the aortic and the superior mesenteric artery. And you must have in your mind this image, these nice images, when you put the scan of the probe to your patient, and what in each moment, what is your position and what is your organs you can see in this image. And also you can find this transverse section, is the transverse section, epigastrial transverse section. You can find here the pancreas with the head, with the body, with the tail of the pancreas, the splenic vein, and also the mesenteric artery presence like a ring. And this is some abdominal cross section. It depends of the position of your probe on the zone of the epigastrial region. And also this is the paramedian left image with the presence of the aorta and the superior arterial mesenteric, and also the celiac trunk. This is the longitudinal section and also the transversal section of this. I try to be in hurry because it's late now. This is the aortic with the superior mesenteric artery in the celiac trunk. And also, if you put a little bit the probe on the right of the patient, you can find the inferior vena cava and also the right part of the liver. And this is the image with the Doppler, and also you can find here in transverse the celiac trunk with the seagull image. And also this is the epigastric. You must know in every moment where you are with your probe, with your hand on the patient, and what you can find to the monitor, and you must have these landmarks. This is aorta, this is the splenic vein, this is mesenteric artery, this is the head and body and the tail of the pancreas. You must have in your mind the Sono Anatomy of the patient. This is some nice image with the seagull image. This is the celiac trunk, and you can see the celiac trunk with the branches of the celiac trunk. Is the left gastric artery, the splenic artery, and the hepatic artery. And also you can find the focal lesion. This is the stomach tumor in the epigastrial region in the section. And I put the elastography, and you can find here the heart stiffness of the tumor was adenocarcinoma of the stomach. And you put the diagnosis, but not very early. This is the most important, to put very early diagnosis. And this is the nice image with the pancreatitis, the chronic pancreatitis, and also an image with an enlarge of the head of the pancreas and the uncinnatus processus, and it is a tumor of the head of the pancreas in our patient. And we use very currently the recurrent abdominal oblique sections, and you can find some focal lesion like this. And this is the what you can find. This is the true section of the oblique recurrent subcostal section, the high. You can find the inferior vena cava with the 3 hepatic veins, and also you can find the second in the deeply position with the probe, and you can find the portal trunk and with the right and the left branches of the portal vein. This is the deep right subcostal oblique, and this is the superficial oblique subcostal and recurrent images. You must have all these to make this examination with the probe in the deeply position and also in the superficial position. And you can find here a steatosis, and this is the multimodal ultrasound. You can have the bidimensional in the grayscale, you can have the strain elastography, you can have the Doppler triplex, and you can find the velocity and the resistivity index in the portal vein, and you can have the contrast here in your patient. This is some segmental division of the liver. Is very important to know if you find the focal lesion to put the diagnosis. Where is you find this focal lesion? And we have some landmarks, as I said, this inferior vena cava, this is the portal vein, this is the Arantius venosus ligament, and this the teres ligament. You have here the caudate lobe, you have here the left liver lobe, you have here the quadratus lobe, the gallbladder, and also the 8 segments of the liver. And I want to put you this nice image with the right liver lobe. You can make the measurements because you have the landmarks, the left liver lobe, the caudatus and quadratus lobe of your patients. And also this is the nice image, but you can find the morphopathological image with your lobe, quadratus lobe. You have the caudate lobe, the quadratus lobe, the left liver lobe, the right liver lobe, the gallbladder, and this is the ultrasound image with all these 8 segments of the liver, and you can put the diagnosis of the topographical liver pathology, focal liver pathology. And also you can make some measurements, the anterior posterior measurements, like in this nice image with the portal vein and the venous ligamentus arantius, because you are in the middle of the liver, in the anterior posterior of the liver in your patient, and you can make some measurements of the lobe, caudatus lobe, to the left liver lobe, to the right liver lobe, and also you have the cirrhosis. This is another case with cirrhosis, with the micronodular cirrhosis, and with measurements of the right liver lobe, measurements of the caudatus lobe, and the multimodal with the heart stiffness, with the presence of fibrosis in your liver. You can find here the blue color, who is represent the heart stiffness of the liver lobe. And also you can make the contrast. You can put the linear probe to have a nice image of the micronodular cirrhosis, like in this image. And also you can find a lot of information through this multimodal ultrasonography. And but in the first time, I want and I advise you to use the bidimensional, the grayscale ultrasound to starting, and you can find some aspects of the enlarge of the left liver lobes, or like in this liver with aspects of the honeycomb, and this is the multicystic liver. And you put the diagnosis in your praxis. This is the stone, gallbladder stones in the stooth section, in the subcostal, and also in the longitudinal mediosternal image. And you can find here the stones. You can find some cystic, some biliary cysts. You can find adenocarcinoma in your patients. You can find the stones, a lot of stones in your patient. You can find a lot of complication, and this is the malign liver tumors. And you put also if you find the focal lesion, you put the Doppler. You can find the high vascularity of the malign tumors, because the malign tumors in 80% are hypervascular tumors. And also you can find in the Zeus, you put the Zeus in contrast, and you can find you have the very good results with the rapid washout of the tumor in the pathology. This is a nice image of the abscess of the liver with the 4D we obtain, and we put the diagnosis on the, and this is the contrast. You make the contrast, you put the contrast, and in the second, in the portal phase, you can see here the rapid washout. This is the tumor, and this is the rapid washout in the few seconds, in the 30 seconds, you have the rapid washout, and you know it's a malignant tumor of the liver. And also we have a lot of nice images with hemangioma, and this is hydathic cyst of the liver with the contrast also. And the hepatic steatosis occur due accumulation the lipids in the hepatitis. And the lipid deposition does not occur in the kidney or in the splenic parenchyma. It's very important to know this, and you can make the differentiation, the ratio between the liver and the kidney to find if your liver is, like in this image, is hepatitis or NASH or non-alcoholic fatty liver disease, and because it's a lot of patients with the steatosis. And you can use the right hypochondrial diagonal scanning for the liver to obtain some information about the hilum of the liver, to see the common bile duct, the trunk of the portal vein, and also the artery, or the hepatic or the liver artery. And also in this nice image, you can find the cholecystis in the longitudinal mediosternal medioclavicular line, in the longitudinal way. And this is the right longitudinal scanning for this, the right anterior axillary longitudinal section. And you can find here a very nice image. This is a conventional image. You can find the kidney, you can find the right and the gallbladder there. And you can find in this space, this is the retroperitoneum, this is the Morrison space, when you can find the ascites, and you can find if in the fast mode, if you have some problem with hemorrhage, internal hemorrhage of your patient. This is the ratio between the steatosis liver and the normal kidney. You can see the differentiation between the echolusity and echoic and hyperechoic liver in this image. And also you can see this differential ratios between the kidney and the right liver lobe. And also you can do the comparison between the parenchymal liver and the parenchyma of the kidney in the strain elastography. And we have a lot of information about this comparison study. And you can find here, this is the steatosis, and this is the increases of the angle of the liver in the corner. And also you can find the cirrhosis and the comparison and the presence in the Morrison space, the ascites. This is the conventional image of this kidney, and also this is an anatomical version. And the differential depends of the direction of your point of your probe. If you are with the pointer in the upper to the head, or if you are with the pointer in the lower to the feet. And this is the differential image. It's like an anatomical image, and you can use the both image if you want, and if you find some pathological lesions to be, and you can have your patient in dorsal, the cubital dorsal, and also in the orthostatism. You can put the patient to stay in the feet to have some differential diagnosis. And you can find here the ectopic kidney or the nephroptosis. You have here the diaphragma, and you have here the kidney, and you can make the measurements between the diaphragma and the upper pole of the kidney, and to find the nephroptosis, because a lot of patients have nephroptosis. And also you can find the hydathic cyst. You can find a lot of stones in your kidney, like here, and with this twinkling artifact in the Doppler ultrasound. And in the left anterior axillary longitudinal section, you can find some information about the left kidney and the spleen. It's very important to have all this image in your mind, and how you put the probe on the patient, and also to have, we starting always in the point of care with the causes of the pain in the left hypochondrium in your mind. If you have the pain in left hypochondrium, you thinking about spleen, the splenomegaly, the tumors, about the gastric ulcers or gastritis, the perforate colon, the colon disease, the pneumonia, the pleural, the heart diseases, and also of the left kidney, the stones, the pyelonephritis, the hydronephrosis, the pancreatic or vascular or aortic aneurysm to see in your patient. This is the normal spleen, this is the normal kidney. You can see the long axis is similarity. You have the ratio, and this ratio is 2/3 of the long axis, and you can find here a splenomegaly, the spleen, the long axis of the spleen is enlarged like the kidney long axis. And also, if you put the strain elastography, you can find the hard stiffness of the spleen, like in this image with the cirrhosis of the patient. And the splenomegaly is very important to have this diagnosis into your patient, because you can try to find a lot of diagnoses if you have the splenomegaly to your patients. This is the splenomegaly with the hard stiffness of the spleen. This is a very enlarged splenomegaly, and you can find here the hard stiffness in the blue color. It represents the hard stiffness of the spleen. The splenomegaly of the patient, the splenomegaly in comparison, this is the normal spleen, and the splenomegaly, you can find you have a hard stiffness of the spleen, and you can make the ratio between the spleen and also the kidney. This is the splenomegaly. The splenomegaly, we try to find some ratios between this, and as I said, you must know the long axis, the ratio between the long axis of the spleen and the left kidneys is 2/3. And you have this ratio in your mind, and you can very easily put the diagnosis of your patient with the splenomegaly, because the patient have a lot of problems, and you have a lot of patients, and don't stay with your nomograms in your front to see what is the normal size of the spleen on the long axis and the short axis, and also of the kidney. And you have some numbers in your head, and you use this all the day. This was a very nice image with the horseshoes kidney. This is the horseshoes kidney, and you can see this confluencing between the left and right kidney. This is the nice image, the left kidney, the right kidney. I try to make this to see this image with the horseshoes. And also the stones in the kidney, the stones in the kidney, the stones in the kidney, the stones in the urinary bladder, the presence of the hydathic cyst. And also you can put the diagnosis of hydronephrosis with the ultrasound classification, and to the stage 1 to the stage 4, when the parenchymal of your kidney is compromised, like in this image, nice image. You can see all the pielocalix and enlarge of the pielocalix and upper and the lower pielocalix, and also the basinatal enlarge, and also the ureterum, and these nice images of hydronephrosis. And you can put the vascularity to see the vascularization of the kidney. And also you can use the 3 or 4D, it's like in this ureterocell. It's a very nice image with the ureterocell with 3 and 4D. And I find here a tumor who produced this ureterocell, I think, or when I put the bidimensional, you can find is a stone. And was a stone in the ureter. And this is the stasis, the pielocalix stasis, and also you can find this, the pyelonephritis, the chronic pyelonephritis. And in transverse hypogastric scanning, you put the probe in the transversal and longitudinal in the suprapubian, and you can find some nice image. You can make the measurements. You can find the measurements of the wall. And also you can find the prostatis to the mens, and this is the 3D to have a very nice adenoma or prostatis adenoma in your daily practice, and also the tumors of ovarian tumors, and this is the prostatis. And also you can find to the tumor, the ovarian tumor of the woman, this ovarian tumors of the woman adenocarcinoma with the hard stiffness of these tumors. And also you can make the testes to see the testes. You can put the diagnosis, the hydrocele, the varicocele, and also the epididymitis or orchitis of the testes, like in this nice image with the epididymis, enlarge of epididymis. This is the hypervascularity of in the orchitis, and also with the hard stiffness of the testes and of the epididymis. And you can find all this in the praxis, in your praxis. And also I put the 3 or 4D to have the enlarge of the testes. And finally, you can make the fast exam, a focus abdominal sonographic in trauma with 4 views. In the right upper quadrant, in the saxophoid, and the left upper quadrant, in the bladder, to see all this kind of presence of the liquids in your patient. This is in the conclusion, like in a lot of studies, you can see the PoCUS has the potential to be an important tool for go to the general practitioners and may possibly reduce the healthcare costs. It's very important. The Point of Care is an instrument in continued development, and the investigation done by the family practitioners is very important. It offers very valuable information on the homes and the unmobile patients. And also, there is a continuous need of standardization and guidance. And as Professor Shlomo said, we need to make a lot of studies in these topics. And in conclusion, there are now insufficient clinical studies in the ultrasonography investigation, but we need a minimum of quality management, standardization, and guidelines based of educational medical continuous. And also, the point of care represents practically an extension of the clinical examination the family doctors in ambulatory healthcare, like a clinical ultrasound examination. Finally, you can see this join of and we invite you to join this PoCUS revolution, and I'm glad I have the opportunity to present this nice image to you. Thank you. If you have any questions.
Are you ready? Okay. Good morning, ladies and gentlemen. My name is Mateusz Kosiak. I am specialist of family medicine from Poland. I'm also co-founder of EUROSON.pl, which is sonographic website for Polish doctors and students who want to educate in sonography. I'm also member of Polish Sonographic Society. Thank you very much, Dr. Michał, for invited me. The topic of my lecture is syndrome-focused sonography. Well, ultrasound examination in hands of specialists of family medicine, as Professor Shlomo said, it's well known, but still nowadays we can hear many opinions like that it's pointless, that it's just a wasting of doctor's time. Or maybe we can see the opinion that it's even dangerous, or even opinion that it's another extra responsibility for family doctors, as well as this is a kind of a madness causing extra crazy ideas or causing unnecessary sonographic examination. There are opinions like that, but the thing is that this is not true. Well, it might have been true 20, 30 years ago, but not now. Why? Because the world is changing. The problem is that our patients have longer life expectancy. Due to this fact, we have multi-diseases, many clinical problems in one patient. Well, I don't know how it works in your country, but in my country we have insufficient number of medical staff. Do you have a free time in your work? Do you have a time for a coffee or breaks? Because when I start my work at 8, I usually finish in the afternoon, and it's patient after another. We really work a lot. Well, the thing is that the same patient sometimes visiting this different doctors with the same problems. If we add to that the defensive medicine, that it's very risky in some poor part of the medicine, and another point that we tend to sometimes complicate things which are actually easy. We come to the conclusion that we need to change our way of thinking about the family medicine, the modern family medicine, and the perspective of the family medicine in 20, 30 years. So, ultrasound examination in hands of specialists of family medicine, it's like an extra physical examination, extended physical examination. Basing on medical history, basing on physical examination, we adding to that sonographic examination so we can fill the diagnosis and make a proper examination. But let me now introduce you how general practitioners, family doctors, can work with a sonographic equipment. The one scenario is that a family physician can control with sonography different conditions like aorta aneurysm, simple renal cyst, hepatic hemangiomas, thyroid nodules. Well, this is the examination where it's performed by specialists of family medicine in his/her surgery, can be performed on appointment book in advance. We don't need to add this extra examination due to the ongoing visit, and actually the main pathology is well known. It's like a control examination, and this is one scenario. But in this lecture we will focus on the other one, on a syndrome-focused sonography, which is a sonographic examination performed by specialists of family medicine in his/her surgery, and it's performed during ongoing visit. And the main purpose of this examination is to establish further clinical decision, but further clinical decisions here and now. And the pathology is not known yet, but suspected. So each time the family doctor places the transducer to his patient, he knows what he is looking for. It's not like the fisherman who's going fishing and whatever he catch, but we know when we start what do we need. We need to confirm or exclude a proper diagnosis. It may be dangerous. I mean, the pathology may be dangerous because the prolonged of time of diagnosis may end up in deterioration of patient's health, and the pathology might be hidden behind the symptoms. And the word symptoms, which is in the topic of this lecture, is a key, is a crucial thing to understand the value of sonographic examination in hands of specialists of family medicine. It's not about one symptom, it's about the list of the symptoms. What is the most difficult when you are working as a family physician? The most difficult are patients with unspecific symptoms. We know who is healthy, we know who is definitely ill, but between being healthy and being ill, there is wide spread of different symptoms who are unspecific. What does unspecific mean? The unspecific symptoms, the symptoms that might be caused by various range of reasons. Some of them are benign, some of them are very, very dangerous, and they require prompt diagnosis. It does not mean that these are emergency patients, which I will explain you in the lecture. The syndrome focused sonography is examination focused on symptoms, not on organs. I can't tell you that it's a liver, lung, or whatever examination. It's an examination focused on the symptoms. It's not about kidney or lung, it's about getting to the proper diagnosis. We evaluate, we examine different organs, different parts of the body during the examination. And we need to consider that we need to be aware what are the most frequent pathology in the different age groups of our patients in family medicine. Well, starting from this syndrome, as we see the symptom as back pain, which is very common, dyspnea, cough, hematuria, right upper quadrant pain, left upper quadrant pain, or breast lumps, it will be about breasts a little bit. Also are the problems when the patient visits us with those problems. Back pain. We know that the most common reason of the back pain is due to spine problems and musculoskeletal problems. But if somebody even has a pain connected with a spine problems, well, if the pain is changing, have different character, let's put a probe for a kidney. On the left hand side we can see the kidney and we can see dilated pelvical system. But why the pelvical system is dilated? So let's put the transducer to the urinary bladder, and now we can see there is a tumor over there. This is the cancer of this is a cancer, as you can see here, in a bladder. There is causing dilatation of pelvical system. But might be another cause of dilatation of pelvical system in patient with acute back pain. Now we are looking at this image, so we can see the stone in not in kidney but in ureter, the tiny little point we can see here. I don't know if I can show it to you with the pointer. On the right hand side you can see twinkling artifact on the little stone which is in the ureter, and we can examine ureters looking for stones and get to the proper diagnosis why the pelvical system is dilated. Recurrent abdominal pain and back pain. The thing is that each time we are dealing with back problems, which is not responding on a classical painkillers, we need to take under consideration the diagnosis which is called pancreatic cancer. And this is what we are looking right now is pancreas, and there is a lesion in the back of the head of pancreas, and this is the pancreatic cancer. Pancreas, it's not so difficult in sonographic examination as it's tend to be said, unless we examine the patient in standing position. The standing position will help us a lot to evaluate the pancreas. Here we can see the tumor of the pancreas in the back head of the pancreas, tiny little tumor. The thing is that the pancreatic cancer may cause different symptoms, and considering those symptoms, please think about recurrent back pain or abdominal pain as well. And if we are looking at the reason of the unwilling weight loss, let's also consider the pancreatic cancer. This is the pancreatic cancer in the head of pancreas. We need to examine patient in a standing position. Hematuria, it might be the symptom which is connected to the inflammation. It might be the symptom which is connected to the cancer. And the patient is coming to our department with hematuria. We put a transducer and we want to evaluate if the patient has or hasn't a tumor in the urinary bladder. Of course, whatever we see in the urinary bladder, we need to put a Doppler on to make sure if there's vascularity. We need to ask the patients to change the position to make sure if the lesions is changing the position or changing the shape. Because if it is so, it's much more to do with kind of a stones or a fluid inside. But if we see the lesion like that, we can see this is urinary bladder cancer. This is the final diagnosis. We see the tumor, we diagnose our patients. But if we are sitting in our department room and a patient is coming to us, the adult patient with right upper quadrant pain, what is the first idea that comes to our mind? Right upper quadrant pain? Gallbladder stones. So we need to evaluate gallbladder. Do we see a stone on this gallbladder? No. We see shadow behind the duodenum, which is located behind the gallbladder. It may mimic stones. So this patient has no stones in his gallbladder. Yes? But he has a pain. So what will we do? We go upper and lower. Lower to the kidney, upper to the, this is what Mihail said, lungs, liver, to make sure if there is a fluid or if there's pneumonia. And this is the simple exam how symptom-focused sonographic examination works. We want to exclude the most serious, the most common reason of pain in right upper quadrant. This patient has no gallstones. This patient has a gallstones, but another patient has gallstone, and also we can see that the gallbladder is not anechoic, it's becoming hypoechoic, and we can see the wall of this gallbladder, it's also a little bit thicker, because the third patient has an inflammation. And which of those three patients should go to the hospital? The third one. We had three people with the same symptoms, three different sonographic images, and we have three different decisions to make. But as you might see, there is a space for patient number 4. So let's look what the patient number 4 will have. He has a stone in common biliary duct, which is not dilated. And the thing is that sometimes we are able to find a stone in common biliary duct even if the duct is not dilated. And let's look on patient number 4, because this is something, a good example of what is sonography examination in family medicine. This patient has the symptoms from time to time. From time to time, she has or he has a pain in right upper quadrant. Well, will she or he require favored diagnosis and treatment? Definitely yes. This patient required ERCP for a treatment and for further diagnosis. Is this condition serious? It is, but it might cause chronic acute pancreatitis. It might lead to acute pancreatitis. So even if the patient is coming to your surgery with no pain because he had the pain 3-4 days ago, we are looking for conditions which might be serious. And what's the problem with family medicine? But it's not very spectacular. That if you do your job very well, actually nothing spectacular will happen. Yeah? The patient will go on, and will be healthy, traveling, and being happy. And the clue is to find those situations that we can prolong life, or find a situation which clinically it's very, very difficult to be diagnostic. Light lower quadrant pain. As we can see, we have very small child. What we want to consider if it's a child with right lower quadrant pain? Appendix. So this is how it works. You don't go like fishermen, you don't go fishing, whatever I catch. You know what you are looking for. We are looking on an appendix. Do you see appendix over there? Here? Long in this situation. We use a linear probe. We have a special technique which actually in the end of the day is not so complicated, but we can find appendix in here, and this is inflammation, appendicitis. On the left hand side there is a normal appendix, on the right hand side there is appendicitis when the appendix is a little bit dilated, and it was also confirmed by the diagnosis. And there is a lady 60 and over who came to you and say, doctor, I have a pain in left lower part of my abdomen. What you are taking under consideration? Mihai was showing pretty image of diverticulitis. Do you see? It's adult patients. We're using linear probe. The patient has a problems with pain in this area. So what we do, we need to place a probe, and we can see inflammation of diverticuli. Diverticulitis, adult patients, and this is how it works. We put a transducer, and we are know what we are dealing with. Is it complicated or not? And we are getting to the proper diagnosis. And there is a child who has a recurrent abdominal pain. The child is not, it's very thin, smaller than his friends in primary school. We place a linear transducer, and we can see bowels with a lot of movements. And the final diagnosis is not from the ultrasound examination. Ultrasound examination is only guiding us to the proper diagnosis. The diagnosis is celiac disease. If you see such intensive peristalsis, if you see a little bit dilatation of the gastrointestinal tract, please think about celiac disease. And there is another patient who's coming to us with abdomen pain. We just put a transducer. We know what is a diagnosis. Diagnosis is constipation, and we use examination to follow up the treatment to make sure that this dilated rectum will make smaller with our treatment. One of the example of sonographic examination is a jaundice. The patient with jaundice come to us. We have various reasons of jaundice, and now let's look on the image. This is the hepatic cell carcinoma. This is the examination in a family physician's room. The patients who just came to us because of the jaundice. This is one of the reasons. What will be the further management? We need to send the patient to the oncologist. Well, another patient is coming to us also with jaundice. We see the dilatation of biliary tract. We can see the gallbladder and the tumor in gallbladder. It was gallbladder cancer, which was pushing the biliary tree, causing the jaundice. But the jaundice might also be caused by liver cirrhosis. The most early sonographic image, the sonographic features of cirrhosis is the margin of the liver, when we don't see the very nice soft margin of the liver, but we see also effusion, ascites, Also, we can see that the margin liver is a little bit patchy liver cirrhosis, and it's another example of jaundice diagnosed in family medicine. Well, we had two patients with tumor and jaundice, and we have one patient with liver cirrhosis. What is the value of the examination? What does the examination changes? What do we know? What can we achieve with the fact that we diagnose that the patient has a liver cirrhosis? We can diagnose the patients, and considering if the patients will not have, for example, bleeding from esophagus in the future, we can do the gastroscopy or arrange the gastroscopy, explaining, going the one step further to find what other complication we might get. This is actually the child. This is the child with liver. You can see from the very beginning that the liver does not look right, that it's not so as it should be, because this alpha-1 antitrypsin deficiency is congenital situation. And this is the jaundice. Also, different patients, different situation, the same symptoms, different things hidden behind the symptoms. Of course, dyspnea, of course, interstitial pneumonia, which was very common and still is very common due to COVID-19. But remember that this kind of image is not only for COVID-19, but also other diseases that might cause interstitial pneumonia. This is image of lung sonography. We can see E-lines, we can see sliding of pleural line, and we need to be aware that if we see such image, we need to consider that this is the proper image, but this patient might has a dyspnea due to asthma, due to chronic obstructive pulmonary disease, and also other situation like pulmonary embolism, which does not changing this image on the peripherum of this lung. And I'm telling about that to understand what are the limitation of sonographic examination. That the fact that we don't see a pathology does not give us the confidentiality that the patient is sick. Another situation, the lady is coming to our department and she said, "Doctor, I have a lump in my breast." And we have three ladies who came to our department one day saying exactly the same thing. "I have a lump in my breast." So let's put a transducer where the lady feels the lumps. Let's look at picture number 1. We have anechoic lesions which enhancement behind the lesions. We don't see any vascularity in a Doppler examination. It's quite soft. We can easily press it with transducer. It's a cyst. It's a BI-RADS 2. And finally, it's very important to understand, if we see such image, do we think that this cyst is not connected very much to risk of the cancer, but we are doing syndrome focused sonography. We are talking about this lesion. We are talking about this tumor. This is what is clinically palpable. It may happen that this lady will have a cancer, or she has a cancer in the moment in another breast, but the different part of the breast. So I'm talking about it to explain that there are two ways of dealing with breast problems. One way is to symptom-focused sonographic examination. The second thing is to examine the breast, the whole breast in details, in case of little tiny cancer which is not clinically palpable, which we can find only in sonographic examination. The third lady, we can see hypoechoic lesion, but the lesion is with the right correct border. Actually, the final diagnosis was fibroadenoma. But if we can see the picture like number 3, fibroadenoma, do we think that the lady has or she hasn't cancer? She has a risk of the cancer about couple of percent. We can't definitely say that it's no cancer at all. We need to accept the fact that sometimes a small number of cancers may mimics and looks like fibroadenoma, so we need to send the patient number 2 for the further diagnosis. And patient number 3 who will coming to us, and she's saying exactly the same what another 2 patients said. Doctor, I have a lump in my breast. We put the transducer and we see the lesions, which is stuffed. We can see the lesions which the border are not so round, and we definitely need to send this lady for a biopsy, a core biopsy, to confirm or to exclude the cancer, because the risk of the cancer in the third patients is absolutely very, very high. So dealing with the breast problem, on one hand side is like sonographic focus examination, but we are focusing on a tumor that we feel in our patient, and basing on the examination we're changing the right diagnostic way. Or another examination is full examination of breast, and it's better in people who are not considering any lesions like prophylaxis or looking something which is not clinically palpable. But as a family doctors, we need to consider, talking about the breast, very important things. What we should consider? The family. Were there any cancers in the family? And genetic background, not only BRC1 or 2, but also other genetic background, like, for example, checks. Well, ultrasound examination in hands-on family medicine, it's not like performing from A to B point, like whole abdomen, because if somebody has a pain in right upper quadrant, maybe it is interesting that he has a cyst in a spleen, but not at this particular moment. We need to deal with the problem that we have. It's more like examining different areas of the body, as you said, gallbladder, liver, lung. It's rather like solving the problems with sonography. It's like extended physical examination. So, who wants to be a millionaire? Do you know it? Who wants to be a good sonographic practicing family doctor? What you need to do? You need to have a good equipment? No. You need to practice a lot? Yes. But what is the crucial thing for you to become a good family physician practicing sonography? You need to be a good physician. You need to be a good in taking medical history, physical examination. It's not like that we are taking our transducer and getting to the patients. Don't remember about the steps like medical history, physical examination, and then the sonographic examination, because then it will fulfill your diagnosis. Does it sound nice? And this is the situation which actually may happen. Well, we need to be aware that sonographic examination has its limitation. I'm sure that I will not find 100% of urinary stones because of limitation of sonographic examination. I'm sure that I will not find 100% of pancreatic cancer because there might be places in tail of the pancreas and in the back of the pancreas. I need to be aware of that and accept the limitation of sonography. Many pathology, one reason. Well, the thing is that if we find a pathology, it does not mean that we find the reason. We find the gallstones, but we don't see the signs of dilatation of gallbladder, we don't see the inflammation. We need to go further and exclude after other diagnoses. And if we meet here, thanks to Dr. Mihail Jakob, we need to think about ours as a lecturer's responsibility to encourage specialists of family medicine to perform sonographic examination, but as well as teach them the proper, standardized, safe examination technique to prepare the list of number of situations that sonographic examination can be useful. Not the list of organs, but a list of symptoms and the situation that the sonographic examination is useful, considering evidence-based medicine, as well as the list of number of situations that the value of sonographic examination is definitely limited. And we need to teach young doctors and family medicine specialists how to avoid potential pitfalls and mistakes, so they will be confident what are the limitations and what the mistake I can do. And do you know what are the most common incidental findings? Liver cirrhosis and renal cancer. This is the tiny little cancer diagnosed in family medicine. Another situation. Renal cancer and liver cirrhosis are the most common situation which you will find incidentally. And getting to the end of this the lecture, point of care sonographic examination, symptom focus sonography examination will increase our effectiveness, reduce the total number of visits, because during one visit we can solve with many problems. It will give us a shortcut to proper diagnosis, and maybe it will help us to deal with diagnosis or with early stage of cancer in a non-symptomatic stage. Thank you very much. If there are any questions,
Good morning, everybody. Thanks a lot for the organizing committee for inviting me. Unfortunately, I will not be with you, but I will try to do my best to provide all the information necessary for introducing all of you to ultrasound elastography. Here are my disclosures, and here is my agenda. I will provide to you background from guidelines, definition, physical principles, indications, some tips and tricks, and finally, take-home messages for all of you. When we deal with any kind of imaging modality, we have to ask how, why, when, and how to try to address these questions. We have to remind all of us, Bernard, who in introduction to the study of the experimental medicine reported that experimental medicine is nothing more than a thinking process characterized by the continuous revision of the ideas by the facts. How to prove that? We need large, multi-center, randomized studies and specific evidence-based guidelines. I had the privilege, together with all friends from EFSUMB and also with EFSUMB, to provide recent guidelines, one for liver and the other one for non-liver applications. And if you download for free, you can find any kind of additional information. Let's start from history. Since ancient Egypt times, the evaluation of a tissue stiffness is one of the bases of medical diagnostics. And the presence of an hard mass was really considered suspicious. And it is due to Hippocrates that palpation became an essential part of physical examination. But we know, we are aware, that digital examination is unfortunately not really accurate. Therefore, we tried to introduce ultrasound elastography-based imaging. It's a new technique mutuated from MRI, introduced in ultrasound that can provide information previously not available. It is based on tissue stiffness or deformability evaluation rather than anatomy. If I ask you, where are we here? Unfortunately, the background is not visible, but if you have something that clarifies the background, it is clear that this is Chicago. Right now, we have different probes, all of them useful and used for different applications of ultrasound elastography. The principle of ultrasound elastography is to acquire dual ultrasonographic imaging before and afterwards. Tissue compression, you may do by means of probe or by means of carotid pulsation. And then you have to track tissue displacement by assessing propagation of imaging beam. Parallelly, we can also use another technique without compression, such as dynamic or shared ultrasound elastography. Several papers published, different guidelines. Let's try to get in how to get it. And what is really important is that we perform elastography with a conventional ultrasound that is equipped with software analysis of frame-to-frame difference in deformation of tissue that is produced by the deformation or by dynamic excitation in order to display how much is soft, how much is stiff. There is a typical example that you can do in real time in order to understand what is the relation between strain and hardness that is represented in this scheme and is reproduced by polychromatic scale. And at the end, you may achieve a different colorization of the tissue according to how much stiff or how much soft it is. What is important that you have a display that shows relative representation of the tissue in a fold of view, in a field of view. Therefore, it can have different shade of gray, different colors reproduced according to the equipment that you're using. And what is important is that you have to learn how to compress, how much you compress, how better you can use your equipment. Here is the representation of the different wave propagation in tissues. This is the longitudinal wave that is reproduced and measured in speed by means of 1,540 meters per second, or the shear wave that is a propagation in transversal wave. Again, another scheme that show you the G model and the K model, and according to them, you can obtain strain or shear wave. Coming back to the external compressive method, you can have external compression or internal one. And you achieve qualitative or semi-quantitative information, or by means of shear wave, quantitative information. And here is how you can do that. Firstly, learn how to compress, obtain a polychromatic box, and then you have also the qualitative indicator right now in real time that show you how to obtain the right and reliable compression, mainly used for thyroid, for breast, for testis, prostate, but not anymore for liver. On the other side, you just press a button, obtain a propagation wave that producially transmitted within a tissue will have different speed changes according to the stiffness. You use mainly for liver, but also for breast, thyroid, testis, and prostate. And at the end, you can achieve this polychromatic map representation and quantitative evaluation. So many actors on the stage, and most of us could be really, really astonished. However, you have to learn from the manufacturer vendors how to use properly your equipment, how to obtain short clips, and then reevaluate in order to obtain the proper measurements. When you deal with strain, you have to be perpendicular. You have to use your probe as an extension of your hand being in plane. Keep the fold large to include several tissue types. For breast, include fat, normal breast tissue and deletion. For thyroid, normal thyroid parenchymal. Compare the lesion stiffness to other tissues, again, fat or thyroid. Use B mode to determine the amount of displacement of tissues and also avoid artifacts. After you learn it, you have to obtain precise, firm, harmonic compression, avoiding the probe sliding and using the right polychromatic box measurement and representation. Look at your polychromatic scale. The color corresponds to soft, vice versa, the opposite corresponds to hard, but you can change it. How to deal with the quasi-static elastographic technique? Use just carotid pulsation, but you have to obtain the right position of polychromatic box, excluding but using carotid pulsation. And at the end, the qualitative indicators show you that you are properly obtaining good results. There are several color-based scale graduation. For breast, this is the first one that was published, and according to it, according to the representation of the color within the lesion, you can discriminate what is called soft from hard. I would like to remind you that unfortunately, not 100% of lesions for breast and thyroid, for example, if they are stiff, they are malignant. Other possible point scale, another one with from 5 to 4 is modified from Lubartelli for thyroid. Other important signs for breast, but also for thyroid. If you deal with the measurement before and after compression, you see that the measurement of a lesion can increase after your displacement. Why? This is due to the desmoplastic reaction of the neoplastic lesion, and it is associated with aggressiveness of the lesion. more evident for breast, and I thank Richard Barr for his contribution to my lecture and for this very nice slide, and also for his experienced and very nicely reported paper that showed us the evidence. However, I had the same impression also for thyroid, and there are evidence that also for thyroid works as a possible worrisome sign. What do? We should obtain the best B mode. We overimpose our probe, we start our compression, then we select the best image, we evaluate qualitatively, and we put two ROI. We were one of the best group, one of the first group to include strain ratio as a possible other application or technique in order to obtain better results. And then you look at the number. If the number is more or lower than a cutoff, you can state that this is a soft or hard lesion. What you have to check when you have done your examination. Polychromatic box should include lesion and enough thyroid or breast in the surrounding tissue. Polychromatic scale, looking at the corresponding color. Qualitative indicator that show you that you have obtained a reliable result. Then you put the ROI, same level, possible, same size, and you look at the number. I show that case, the same cases with different number. Why? Because unfortunately here, the ROI was within the thyroid and not only within the thyroid nodule. Therefore, I repeated and I obtained a different value. And this is important. Check ROI position. 3D, 4D, in real time. Now, these are trying the vendors to provide to us the possibility to have a volumetric acquisition. And I showed in some of my paper, this one was published in International Journal in Endocrinology, that can be used especially for guiding and for evaluating minimally-invasive treatment. However, there are some pitfalls that you have to take in account, and there are some rules that you have to follow. May or should I have to use elastography in any lesions? The answer is not. If you see that the lesion has a big, extensive area, and you put the ROI there, you obtain false positive results. If you find that there is a grossly calcification, you obtain again a pitfall. And also you have to deal with some artifacts. RGB sign, typical for a multi-layered cystic lesion, or rainbow sign that we found in follicular aplasia of the thyroid, and is another sign that can help us to downgrade the characterization of the lesion. I suggest you to read some of our papers that we published in a special issue in European Journal of Radiology, because we found and we reported all the limitations of this technique. Firstly, carotid pulsatility. Secondly, operator dependency. You need to be trained. At least 100 examination guided by experts after you have read the right book, the right papers. Then you have to deal with the polychromatic map variability of the colors and patient dependency. At the end, we can conclude that strain ultrasound elastography has the advantage to be a real-time compression quality control, to be efficient and providing reliable polychromatic map, and needs not so long time to be trained. However, it is still a qualitative, semi-quantitative technique. Share wave, we need something else to provide quantitative evaluation. We have several different techniques, single point, 2D, 3D. You apply a patch pulse, then there is propagation wave, and at the end, you can obtain a quantitative evaluation. Again, voxel, box, position, and technique are really important. Here is an example of what you can do really in real time. And there are some of my experience already published, as in this case, we did put with single point, share wave, one ROI, and at the end we obtain a measurement evaluation, 2D share wave. We have a polychromatic maps. We include tile nodule. We put a ROI and obtain again measurement. Single point share wave, 2D share wave with the new RMI, reliable measurement index, providing to you easily different measurements. And at the end, you put together, you obtain a profile and the final results for it. Other example of our previous examination, and again, different way of visualization of 2D share wave, providing information expressed by kilopascal or meter per second. And you have to check quality control, you have to check the values and providing your results. Also for breast and also for share wave, there are different possible scales for dividing the negative to the positive lesion. Here is again a nice example of how important is the qualitative B mode. Then the ROI, you can draw your lesion, you can put circular ROI. You have to be consistent in your measurement. You follow the qualitative indicator and you obtain good and reliable results with the possibility also of 3D representation in different planes. If you look at BUFUM guidelines, there are also some other tips that are reported. When you deal with very superficial lesion, sometimes it's really difficult to obtain a reliable result. There are different methods. Still, there is not completely the evidence on one favoring the others, but later on, tomorrow, I will provide to you clinical application for thyroid, for salivary gland, for testes. If you look at what we have right now for liver, we have a very extended and technical landscape.